Good morning. Welcome to another online educational event brought to you by Parkinson's Community Los Angeles. Today, we are talking about the latest in Parkinson's treatments with movement disorder specialist, Dr. Melita Petrosian. I'm Patrick Lasasso, president of PCLA's board of directors. For those of you who don't know us, we are a Los Angeles-based 501c3 nonprofit that supports families living with Parkinson's disease through free online education events, support groups, information and resources, our annual Living Artistically art show, and so much more. Today's Let's Talk Parkinson's program is brought to you by our wonderful sponsors, Abbott, AbbVie, Boston Scientific, Medtronic, and Supernus. Our mission also relies heavily on your donations. So if you value the work we do and want to help us continue, please visit PCLA.org, click the donate button with the little red heart in it, and make your tax-deductible donation today. It's so easy, and thank you. On to our presentation. A few quick notes before we start. We are recording today's event for our YouTube channel, so those that can't attend today will also benefit from this presentation. If you don't want your image recorded, please turn off your video. We will remain muted to keep background noise at a minimum. If you have questions, submit them into the chat feature at any time, and I'll read them during our Q&A at the end. We are so fortunate to have this presenter for you today. Returning to PCLA's Let's Talk Parkinson's series is the wonderful Dr. Melita Petrosian. Dr. Petrosian is a fellowship-trained neurologist and movement disorder specialist and director of the Pacific Movement Disorders Center at Providence St. John's and Providence Little Company of Mary Medical Center, Torrance. Her clinical interests and expertise are in movement disorders as well as Parkinson's-related conditions. Melita treats movement disorders with a multidisciplinary approach, utilizing the latest techniques for diagnosis and treatment. She encourages the integration of therapists for physical, occupational, speech, and other evidence-based approaches to improve outcomes in treatment of motor and non-motor symptoms. She is a member of the American Academy of Neurology and Movement Disorder Society. Please join me in welcoming Dr. Melita Petrosian.
Thank you for that warm welcome, Patrick. I really want to give you and your team kudos for the wonderful event you had earlier this month. I was blown away by the art that was presented, and more so, thought it was just a wonderful way for people to get together and talk about art and not talk about Parkinson's. It was really a wonderful way of getting people together, and I really want to commend you and your team. I want to let the audience today know that today's talk is a little bit different than what I usually give. I did want to touch on some of the most recent stuff, but obviously you kind of have to start from the background a little bit. So some of the kind of information might get a little bit into the weeds. Some things might be a little bit basic, but I wanted it to be a fairly brief talk, which I always promise and can never seem to deliver on, because I wanted a little bit more focus on the Q&A than I normally have time for. So hopefully this will just be almost like a jumping off point or an inspiration point for, a lively Q&A session. Oh, what's going on here? Why did that not advance? Let's see, I'll just use my, there we go. So to click more deliberately, I guess. Okay, so, just to start with, I think most people on the call are aware that a lot of Parkinson's symptoms, but not all, of course, are related to low dopamine in the brain. And so a lot of our treatments thus far have been focused on boosting dopamine in the brain. So I just wanted to sort of give people a sense of where is that in the brain and what is happening when we're using these medications, to then be able to have a better sense of, when we talk about what's new in Parkinson's, why is it that we're using these medications? So one of the obviously mainstays of treating Parkinson's is levodopa, which gets converted in the brain into dopamine. But in order for it to get into the brain, it's taken with a dual medication that reduces the breakdown of the levodopa outside of the brain, gets more of it into the brain, and that's called carbidopa. So sometimes we'll use the term carbidopa-levodopa, L-dopa, levodopa, Sinemet, all of that is equivalent. The dopamine then gets taken up by dopamine receptors And so there are medications that can also work on dopamine receptors separately, and those are called dopamine agonists. And those include pramipexole, ropinirole, rotigotine, which is the Nupro patch, and apomorphine. And then dopamine gets broken down into its metabolites. And so there are medications that reduce the breakdown of those medications, which include rasagiline, selegiline, and sulfonamide, medications that reduce the breakdown of levodopa, including entacapone and opicapone. So as the years go by, a lot of people with Parkinson's, but not all, will experience what we call off time. And what that refers to is a switch from the medications kind of acting smoothly over the course of the day with the amount of the brain's natural dopamine being enough to cover the symptom management while as the medication wears off. So in the sort of first several years of the condition, the medication may not be felt as kicking in or wearing off necessarily by the patient. They may sort of feel like most of the time they're in this sort of good zone. Now, please bear in mind that this is obviously vastly oversimplified just for sort of the purposes of kind of having a way of envisioning what's happening. But the theory behind it is that patients whose medication has worn off, they feel low dopamine, off, meaning slow, stiff, stuck, shuffling. And then if the medication is too much, theoretically too much levodopa, they might experience dyskinesias. Now, again, this isn't nearly the full picture of exactly how dyskinesias occur. Not everybody gets dyskinesias, but there are some people who will sort of cycle between, on that right side of the chart of the slide, either feeling off or on with dyskinesias with not enough time spent in the well-controlled sort of blue bar. So a lot of the new medications that have been approved for, that should say 10. I just realized I added one last night and I didn't update the top part of my slide. Sorry about that. There are 10 quote unquote new medications for motor symptoms since 2014, although the top one and the bottom one on the list are carbidopa levodopa, just in different formulations. So many people are familiar with Rytary as being an extended release form of carbidopa levodopa. It can last longer than immediate release carbidopa levodopa. Some people may not be aware of Divi, which is the one on the bottom there. It is, again, just carbidopa levodopa. It is an immediate release form. Honestly, it's really not that different. It's the only reason why it's new is because it's easier to break into smaller pieces. So most of my patients, if they have to take like a half tablet of the carbidopa levodopa, it's not too hard to make that a fairly even split. But if somebody's very, very sensitive to going a little bit smaller or a little bit bigger in the split of their pill, Divi is available in a much cleaner break to cut it in half or even to cut it into quarters. So that's the sort of new, it's not really new, it's the same old thing, but in a new formulation. Another levodopa based medication on that list is Duopa, which is a pump that infuses levodopa directly, carbidopa levodopa directly into the intestinal tract, so that people who are having difficulty with the oral medication, as they're taking it, their levels are going up and down and up and down. This instead will provide a continuous infusion over the course of the day so that it's not going up and down. Another of the medications that is levodopa based is Inbrija, which is an inhaled form of levodopa. And that one is levodopa alone. It only works as a rescue, I like to call it, or a bridge for people whose dose has worn off before they're due for their next dose. The other medications on that list include an MAOB inhibitor. That's the one that helps break down the helps stop the breakdown of dopamine. That one's called Xadago. It's fairly similar to the other MAOB inhibitors, and it's somewhat mild in its efficacy. And then we have two quote unquote new medications, Gocovri and Osmolex, that are different from the ones I showed on the other side. They're called amantadine, which is a different way of regulating dopamine release in the brain, and can both reduce off time and reduce dyskinesias, which are the issues that we get if we're giving too much levodopa of one form or another. And the final two, three medications that are newer are Nurians, which works by actually a completely different mechanism. Instead of giving more dopamine, the way Nurians works is by reducing the brain's stop signaling. So we can think of the brain as having go signaling and stop signaling. And the Nurians works by limiting the stop signal in the brain. So it can really boost the efficacy of levodopa. Kinmobi is a dopamine agonist that is used as a rescue by being absorbed under the tongue, only works very short periods of time. So it only works as an as needed medication. And then Ongentys is a newer type of COMT inhibitor. So it works by reducing the breakdown of levodopa, and it is effective. It was compared against the older medication in that class, which is called entacapone or Comtan, and that one is the Ongentys is more effective than the entacapone in that study. So I didn't want to spend too much time on this because I wanted to, again, like I said, give a little bit more time for questions and sort of give a sense of like, this is the progress that has been made. So there's definitely been a lot of people who have had improvements in their quality of life with these new medications, but we're still only talking about motor symptoms, and we're still not, this isn't talking about, well, how are we stopping the progression of the condition? But there's also some really interesting work that's being done on, well, how do we know when we're off? You know, a lot of my patients will ask me, like, what does that mean off? What is it that you're referring to? And how do I know when I'm off? And also people will obviously not necessarily remember the full details of like how many hours are they on versus off, and how long does each medication last. And so in order to kind of supplement the information that patients can remember to tell us, or sort of their feeling of it, there are a couple of newer ways of assessing motor fluctuations. So again, just as a reminder of what does on mean, what does off mean? So on means the medication's working, the slowness, stiffness, and tremor is as low as it is going to get with that dose. And people are generally feeling okay. People can be on, but be struggling with, say, a non-motor symptom of Parkinson's, like fatigue or constipation or insomnia. So on doesn't mean all of the symptoms have gone away. It's just that really kind of narrow view of the motor symptoms. Off is where, again, the medication has worn off. Let's say they forgot to take it, they took it and it wore off too quickly, or after they took the medication, it took a while before it kicked in. Or sometimes people will say, you know, I just didn't feel it kicked in at all. And so those are the terms. And then it's a little bit hard to read. I'm sorry for the smallness of it, but traditionally in research setting, the way that we would ask people about off time, or sort of ascertain their off time, would be with this formal motor diary called the Hauser diary. And we would ask people to check off for every 30-minute interval, whether in that 30-minute interval they were mostly on, mostly off, asleep, or on with troublesome dyskinesias. And again, dyskinesias are involuntary movements. They can include head movements, hand movements, legs, trunk, but dyskinesias do not include tremor. So tremor is that sort of rhythmic activity that's from the disease, and dyskinesias are induced from the levodopa. So as you can imagine, it's really hard for people to figure out within a half an hour, what was I doing, especially if they're not doing it in real time. It can get really messy. So the newer kind of ways of looking at what are people's motor fluctuations include the Parkinson's kinetograph, or PKG, which is from the company Global Kinetics. And people wear the watch, and then after about a week, they put the watch to charge, and then they get a report transmitted electronically to their physician. And this on the right is what the report looks like, where they can report on tremor, dyskinesia, meaning involuntary movements, and bradykinesia, meaning slowness or stiffness. So in this particular example, the red lines denote when they're due to take their medication. It gets like programmed into the watch. And the watch will give the patient a reminder: you need to take your medications at 6, 11, 4, and 9 p.m. And the patient on the bottom, in these little red dots, that's when they acknowledge that they took their medication. So maybe they took their medication an hour late, 2 hours late, maybe they forgot. They have to swipe the watch to acknowledge that they've taken the medication. And then you can see this pattern emerging here. This is a very classic traditional pattern where, you know, after they take the medication, their motor scores, meaning their slowness, their bradykinesia, improves to the green zone. That's where you want to be, is in the green zone, for a couple of hours, but then it wears off again. And they take the medication again, it improved again, wears off again, et cetera. Sort of that cyclical on and off kind of experience. But at the same time, in the top part here, this orange colored part of the graph, the lines, shows a dyskinesia. So they're getting involuntary movements peaking around the same time that their medications are on. This is a very classic pattern. Of course, it's certainly not the case for everybody. And some people whose dyskinesias manifest in their jaw or in their foot, it may not really show up because the watch is really only worn on the wrist. Similarly, if somebody has tremor only in the foot, it really isn't going to show up. But it does a very good job of kind of being an adjunct to the person's kind of experience of, you know, I'm feeling on or off over the course of the day. And it can be linked to, okay, well, this is the time you took your meds, and this is what it looks like when you're taking your meds. And if nothing else, I've certainly found people find that when they're wearing the watch, they do take their meds more consistently on time. Another more recent development for evaluation for motor fluctuations is called the Strive app, which goes on an Apple Watch. And so this wouldn't be a separate device that is only worn for the purposes of the Parkinson's. This is a regular Apple Watch that has all of the functions of an Apple Watch, but the app takes use of the information from the kinetics and accelerometry of the Apple Watch to, as well as like heart rate and things like that, to give a report that can be accessed at any time. This is a little bit of a busy slide to see, and obviously this isn't a particular patient. This is their kind of stock, Jane Doe, as it were. They have a name, but it's not a real name. And so this one doesn't detect or report bradykinesia. It detects and reports tremor and dyskinesia only. Sleep, the person marks in their app when they've taken their medications, and they can also mark how they're feeling and how they've exercised and things like that. If somebody has Medtronic deep brain stimulation, which we will talk about later, those brain sense signals can also be incorporated into the app and provide provide data for the clinician to say, okay, this is what your brain signals are sending us. This is what the tremor looks like, or the dyskinesia looks like, and sort of to help guide, you know, what that will look like as far as managing the DBS. Obviously, you know, people don't need to have had DBS in order to utilize this app. And in fact, the company doesn't require you to have an Apple Watch. They will send you an Apple Watch if you sign up for using it. So I think what I like about this is that for a lot of people, I have a lot of patients who wear an Apple Watch, and I find that, it feels less medical. It's like, oh, I have an Apple Watch and it doesn't have to kind of broadcast that I've got Parkinson's. Not that the PKG says anything about Parkinson's on it. Obviously, it's in development in terms of nicer looking prototypes of it. But the Apple Watch can also be used for, tracking the exercise and fitness and sleep and oxygen levels and heart rate. And for some people, EKG. So I think it's nice to kind of have everything all in one place. So we'll talk briefly about DBS for Parkinson's. Again, this is really a much shorter, supposed to be a shorter talk so that we have more time for questions, but I wanted to remind people that DBS is a pacemaker for the brain. It allows the efficacy of the medication to last longer during the day. For some patients who have trouble tolerating levodopa and other medications for Parkinson's, we have actually sometimes used the DBS as a substitute for levodopa. But certainly the traditional concept would be if somebody's has tried levodopa and they didn't actually respond to it, they're not going to be a great candidate for DBS. It's really for people who are experiencing off time and dyskinesias, and all those meds that I mentioned that have come through in the last decade aren't working well for them, and they need a surgical approach. It also works well for essential tremor and tremor from Parkinson's. That is to say, if somebody's medications just aren't cutting it for the tremor, the DBS can be very helpful for that. The recent advances in DBS for Parkinson's include that it is now MRI safe. And it's not just Medtronic that is MRI safe. That's Boston as well as Abbott, I believe, have MRI safe DBS platforms. The fact that Abbott and subsequently Boston Scientific started to get into the market about 6-7 years ago has really ramped up the advances that have been made, because DBS was very static for a couple of decades until there was some competition, and so finally have been advances made in the technology. There's now the ability to record brain activity. Abbott's device has Bluetooth programming, so it is now able to be programmed like through telemedicine, which is a really important thing if somebody's living very far from a DBS center. Boston Scientific has a very unique kind of control of the stimulation where it can be nuanced in a different way in terms of where to angle the stimulation. Boston Scientific and Medtronic have newer ways of showing within the programmer how and where the stimulation is hitting in the imaging of the person's brain. So that's a really cool kind of way of controlling the stimulation better. Also, I think advances that have been made are the rechargeable batteries and batteries lasting longer and that kind of thing. So really some really interesting advances there. The devices have gotten smaller and the wires have gotten thinner, so they're becoming more comfortable for people to wear. So just more specifics about Brain Sense, which is a way of getting information from the brain on what are called local field potentials. We call it the beta band, which correlates with symptoms of slowness and stiffness. And it can really line up well with what's happening with the medication and what's happening with stimulation. So it actually helps us program in a more direct way. This is what the screen will look like. The patient can actually mark in their app, oh, I was feeling on, I was feeling off, or I was exercising, or I had dyskinesias, and then we can sort of link that to what's happening in the brain, like what the brain signals are. Again, on the right is an example of being able to sort of visualize in a 3D way where we're programming within the actual images of the brain, which is again also available through Boston Scientific. And I think is a really quite a boon to programming in a more anatomically accurate way. What we're expecting next is not available yet, but what we're expecting next for DBS, now that we have ability to not just stimulate the brain, but also to pick up the signals coming from the brain, is that the brain will then, excuse me, the DBS won't just give the stimulation continuously, but rather will only give stimulation when certain parameters are present. And so it'll actually turn the stimulation on and off in a way that is ideally not felt by the patient, but rather is resulting in the battery being less used, less overstimulation, and, you know, essentially only using it as needed rather than a continuously on state. So we call that adaptive DBS. So that's not available just yet, but I think it will likely be available very soon. Another sort of newer treatment for focused ultrasound, this did get FDA approved in 2018 for tremor predominant, and then 2021 brought the approval for dyskinesias and Parkinson's. So this is called focused ultrasound, which is, I think a lot of people have heard about this. It's a way of delivering about 1,000 beams of ultrasound to the brain, and using those beams to actually heat a very tiny part of the brain to calm down, or like actually to create a lesion and to silence that overactive part of the brain. So in a way, this is a new technology that harkens back to an older way of surgically treating Parkinson's, which was way back in the day. The surgeons used to actually create lesions directly in the brain. Then DBS came about, and that kind of fell out of favor. And now we're sort of come full circle to putting a lesion in the brain, but instead of doing surgery to do that, they're using a non-incisional approach. I don't like calling focused ultrasound non-invasive because it is a brain procedure. You are putting a lesion in the brain. So I don't like that term non-invasive, but I will say it's non-incisional. For tremor predominant, there's a particular target that's used. It can only be done unilaterally for now, although that might change in the future. And they did show 62% improvement in tremor compared to 22% in the sham group. And then in 2021, the FDA approved focused ultrasound for a different target in the brain called the globus pallidus, and they showed 50% improvement in dyskinesias and motor scores with that. People always ask me about focused ultrasound, and I say, well, what are you referring to? Because there's high intensity and there's low intensity, and those are two separate things. High intensity is creating a lesion. It's a permanent lesion. It is a kind of a one and done. There's no programming that's needed. There's no adjustments that are needed, but conversely, there's no ability to adjust it. It's once the treatment is done, it's done. This other treatment, this low intensity focused ultrasound, is entirely experimental. It is not it's nothing that has been approved or even proven to work, but people are asking me about it because UCLA is sending out some emails regarding a clinical trial that they're enrolling that I think is really promising, but it's a very different kind of concept. The idea is that with the low intensity focused ultrasound, you're not creating a lesion, you're not doing anything permanent, you're not that one will truly be non-invasive. But at the same time, it isn't, if there are benefits from it, they would not be permanent. So there is a clinical trial that's enrolling for that. So obviously you guys know me, well, most of you who know me know that I can't not talk about exercise. So this is new information about what we always knew. It's sort of new confirmation. This clinical trial came out, this study came out in earlier this year. What it showed was that when we followed people, I shouldn't say we, I wasn't part of the study, but when they followed people for a close to 5 years, they found that those who were exercising were associated with a slower deterioration of their walking, their postural stability, their activities of daily living, and their cognitive processing speed. The exercise that was most associated with better outcomes at 5 years were moderate to vigorous exercise. So thinking like high intensity cardio or progressive resistance exercises. Whereas when people were doing work-related activities, so for example, if somebody is, working as a working as a waitress, it's a very physical job. They're moving a lot. They're not sedentary by any means, but it's not exercise per se. So work-related activities didn't show as much benefit, but was associated with a slower decline in processing speed. And then household activities like laundry and vacuuming and doing the dishes, again, not sedentary, but not the same as exercise, was associated with just a slower decline in the activities of daily living, but didn't have all the benefits of moderate to vigorous exercise. So again, just proof of what we always told people, it actually makes a difference in your outcome. And these were people where, they were sort of at the same baseline kind of coming in as far as how much exercise they were doing or how fit they were to start with. So the concept is that their exercise was associated with what they looked like in 5 years' time. Just briefly wanted to let people know, because the question is what's new. So there have been some clinical trial updates, some things that are still enrolling. There's, medications that are being assessed for managing constipation in Parkinson's. There are medications being tried for a particular gene called LRRK2, which when it's overactive contributes to Parkinson's. So this is a LRRK2 inhibitor, and they're testing it for people who do and who do not have LRRK2 abnormalities in people with Parkinson's. That's going to sort of, the news is that it's starting to enroll. I didn't see any local sites yet, but it likely will have some local sites. So you can check into clinicaltrials.gov to find out more about that. The tyrosine kinase inhibitor that is from the company Spark is going to be enrolling for a phase 2 for early stage Parkinson's disease. And we will be a site for that. There was some also really interesting in vitro data about how LRRK2 plays a role in Parkinson's. So they actually developed something called a nanobody. So this is like a kind of like a not just microscopic, but a tinier version of an antibody that they actually derived from llamas, which is really fascinating. And they showed that they were able to inhibit LRRK2 in vitro, and they believe that it's going to work differently from how the more traditional antibodies were working. So again, the concept is that there's really a lot of people who are putting a lot of effort into thinking about really novel ways of approaching that. What we're talking about with LRRK2 and with the tyrosine kinase inhibitor, and what we're talking about with the GLP-1 receptor agonist, the liraglutide study, all of that is trying to figure out, well, what everybody wants to know is, how are you going to stop this disease? How are you going to prevent it from progressing? Is there a point where there can be a cure? And so that is this kind of work. It's different from talking about, oh, these are the medications we're using now. These are the new medications we have. All of that is about managing symptoms. This is the other side of the coin is, well, how do we actually slow progression? We know for sure that exercise, as I mentioned before, and diet are associated with slowing progression of Parkinson's. So that's really key to keep doing, but we're still working hard on finding more than just that. So the liraglutide study, a lot of people were asking me about that. It did show the improvement in non-motor symptoms, activities of daily living, and quality of life. So that is going to go on to other studies to see how it and other drugs in its class do for preventing progression of Parkinson's. And then there's been some, more, smaller kind of the beginnings of things, looking for how are people going to do with a completely novel way of breaking apart the alpha-synuclein that clumps together and contributes to the cell death in people with Parkinson's. So that was just a very beginning study. And then I wanted to finish with something that was very new to me. And there was a study again earlier this year that I was really blown away by. And, it's a little bit of a tricky topic, but I was fascinated by the concept of this study. There's a wonderful researcher named Bas Blom. He's in like the Netherlands, and he's always on the forefront of not just, okay, well, how do we treat Parkinson's? Like, he's helped developed a lot of these newer medications, but he's also really just approaches it from a completely different angle. And so every time he has a lecture or a paper, I'm just fascinated by it and just feels like my world has been shifted. And so what happened was he had a patient who came to him and asked him, well, Dr. Blom, like, is there any silver lining to having Parkinson's? And I don't know where that patient was coming from as far as why he asked that question. But, Dr. Blom's initial gut reaction was like, no, of course not. This is a terrible disease, and, people are suffering, and, why would there be a silver lining? And then he sort of paused for a moment and sort of reflected on it and thought, well, I'm not really the right person to answer that question. Really, people with Parkinson's should be answering this question. So he very kind of loosely and informally did a social media kind of exploratory survey, if you will. And he found that of the people who responded, which of course is a biased group, we can imagine, 82% of people responded saying that they were able to identify at least one positive experience that they had had as a result of having Parkinson's. And that included a greater appreciation for life, a change in life philosophy, better, healthier lifestyle, which I've heard that a lot with my patients. A lot of my patients will tell me they feel more fit than before they had Parkinson's. Some of them felt that they were gaining some personal inner strength and changes in their personal relationships and activities. Of course, not everybody felt this way, and people did respond saying that there was absolutely nothing positive, and almost being offended by the thought that there could be any kind of silver lining. And obviously the conclusion is that a silver lining is still part of a cloud when the cloud is there. But I think the concept of rethinking what we mean to be healthy, this sort of positive health definition that came in 2016 is very, very different from the original WHO definition of health, which is a state of complete physical, mental, and social well-being, which almost seems unattainable. Like, I'm not sure who I know who fits that definition. It's like, is that something that is too perfect to be attained to the majority of us? And so if we reframe the concept of health as the ability to adapt and to self-manage in the face of social, physical, and emotional challenges, we can say that, quite a large percentage of our Parkinson's patients are healthy, and that they are living with Parkinson's, but they're, that they themselves might sort of reframe how they're thinking of themselves. And I think that while we don't necessarily want people to go too far into denial, because I have seen that, I think that there's really a value to sort of reframing and sort of reconsidering what we mean by health and what we mean by what is a healthy living in the context of having a chronic condition. So that's a little controversial, and I apologize if I've offended anybody, because as I've always said, I'm an expert, but I'm also an imposter because I haven't walked a day in your shoes. So I recognize that it may be a little bit too easy for us to say it, but again, these were respondents with Parkinson's themselves who were identifying these kind of positive experiences. So I think it's important to have space for that possibility in our minds. So I just wanted to end on that and open up to questions.
Oh, thank you so much, Dr. Petrosian. This was absolutely fabulous. And I actually love the way you wrap things up with that. That was a really, regardless, I understand the sensitivity of it, but I don't think I've ever heard it looked that way before. So thank you for sharing that, Dr. Bloom, I guess was his name, with us. So we have a lot of great questions here. The theme is the latest in treatment. So we're going to try to get to all the questions, but I'm going to try to kind of filter them out a little bit and start with the ones that are referencing treatment. What about trihexyphenidyl?
So trihexyphenidyl is the brand name for that is Artane. It's not new. It's been available for quite some time. It actually was used very traditionally for Parkinson's before levodopa came out because it's what's called an anticholinergic, and it sort of indirectly can boost dopamine. So we use it sometimes for people who have either tremor or dystonia, whose symptoms aren't responding to levodopa or who can't tolerate it. I tend not to use it in my older patients because it can cause confusion, and especially as people get older. So if anybody has any kind of cognitive issues, I wouldn't even touch it. But in addition to that, it can also cause dry mouth, constipation. So it doesn't have as large of a role, but I certainly have some people where it is helping them, especially a younger patient.
Thank you.
It is not a disease modifying treatment, so it's just for symptom management.
Okay. Can you talk about glutathione treatments? I have a deficiency due to triple mutation that runs in my family, which causes tremors and bradykinesia. That's, yes.
Very interesting. Yeah, glutathione is a very, I think, interesting medication that I kind of fear it's sort of been stalled in the development of it because it is available as a supplement. So I've had, I've noticed that when something is available already to be sold, then if there's a reasonable kind of concept of why it might work for Parkinson's, then there's not really a motivation to confirm that it for sure works for Parkinson's, because it can just be sold without proving it, as long as a supplement manufacturer isn't claiming that it's treating Parkinson's, then they can really sell whatever they want. So I have a hard time recommending that everybody with Parkinson's take glutathione. Obviously, if somebody has a glutathione deficiency, then that's a separate thing. But for the average person, I think that there's some reasonable theory behind it, but I can't really recommend it as a wholesale. And I think that it really wasn't found to be effective when taken orally, and it was more the intranasal approaches that were more effective.
Thank you. I started levodopa carbidopa a few months ago and seem to continue to have motor symptoms with it, but feel better in general when I take it. Does that make any sense?
Yeah, unfortunately, levodopa isn't a, perfect replacement for natural dopamine. It helps boost it, but it's not, I don't think it's hardly ever 100%. I sort of have a very tiny subset of patients who tell us, I feel like when I'm taking it, it's like I don't have Parkinson's, and that's not common. It's more common for people to say, oh, I definitely feel better. I feel like I can function better, but I still get tremor when I'm nervous, or I get, stiff when I'm tired, or more typically, for me to be able to catch it on the exam, for me to be able to see that, oh, they still have Parkinsonism on exam, is just better. So that's fairly common.
Okay, there's an amendment to this as well. Hi, I was diagnosed 2 years ago at 61. My question, is there a way to measure the levels of dopamine in a person's system? Is there an optimum level in this regard? Are there norms for dopamine levels, or does it differ widely among individuals? It's a great question.
Those are fantastic questions. Unfortunately, there really isn't. So blood level, dopamine in the brain levels don't show up in the blood. It's just not going to show up. There's a lot of biomarkers that have been developed for Parkinson's, but for primarily what they're looking for is, does this person have Parkinson's? What's happening in the brain? So for example, there is a blood test that is going to be looking for that abnormal alpha-synuclein I alluded to earlier, to kind of try to distinguish, is this a person with Parkinson's or not? That one remains to be seen, like how effective it is as a prospective biomarker. A prospective biomarker, a good example would be like PSA. the, prostate specific antigen. Like, it's not perfect, but if you follow it with time, especially if somebody has prostate cancer, you can say, oh, they're responding to treatment or they're not responding to treatment. You can monitor something based off of it. You don't have to wait for something bad to happen like metastases. You're monitoring the PSA. We don't have that for Parkinson's. We don't have a prospective way of monitoring. How are they doing? How are they evolving? How is this treatment helping them? All we have is, what do they look like clinically when they're taking the treatment? We do have biomarkers that are diagnostic. So that's the DAT scan, which sort of measures dopamine levels in the brain, but it's a gestalt. It's sort of like, is it normal or is it abnormal? It doesn't really quantify a level. And then we have the SYN1 biopsy, which detects alpha-synuclein in its abnormal form in the nerves of the skin. But again, that is also just does this person have Parkinson's or not? And both of them don't really distinguish between Parkinson's and Lewy bodies, which is a whole other talk, but it's really not actually getting at what are their dopamine levels. Should they take their meds now or should they wait an hour, and that's why I think things like the PKG and the Strive PD app, I think that's where we're going to be hopefully getting a little bit closer to how can we know if we're taking the meds correctly, on time, up and down. And yes, there are, wide levels with individuals, but there's not norms because it can't be tested in the blood.
Thank you. Some DBS related questions. I have a titanium plate in my forearm from a previous surgery in 95. Do you know if this would preclude getting DBS when using an MRI? And I had my DBS 2 years ago. Will I be able to have the adaptive DBS?
Great questions. The first one, no, titanium is not a problem. It's a non-magnetic metal, so that's not an issue. The question about adaptive DBS, it may or may not. It really depends on what kind of DBS they had. The platform that seems the closest to getting to adaptive DBS is the Medtronic platform. And I know that the Medtronic newer implanted pulse generator or IPG, we call it a battery, is compatible with their old leads. So, nobody's ever going to replace brain leads when new technology comes out, because the biggest risk of the procedure is the actual placement of the lead. So we're not, nobody's going to take out leads, put new ones in unless there's something bad like an infection. So the question is, when the battery gets replaced, will it be compatible with the leads that that person has? And the question is, it might, but it really depends on which platform it is. And so it's a good question to ask their neurologist.
Are there any new developments with more, quote, natural, unquote, treatments, for example, acupuncture?
Great question. So as far as natural treatments for Parkinson's, as I've said before, I think it totally bears repeating: exercise, exercise, exercise. I'll say that 5 million times. Diet, I think the MIND diet, which is the Mediterranean intervention for neurodegeneration delay, say that 5 times fast, has been associated with a slower progression of Parkinson's. They actually showed that even when people turn to the MIND diet late in life, like after diagnosis, it still was associated with an improved outcome. So I have a lot of people who say, well, I'm 80, I'm not going to start eating right now. And I'm like, you still should. You still have time to do it. Sleep, very, very important natural treatment for Parkinson's. When people sleep well, sleep hygiene, cognitive behavioral therapy for insomnia, all these things makes a huge difference, not only for how they feel, but how the disease progresses. Therapy for depression or anxiety, I think of as natural. I think of joy as being really important, gratitude as being really important. So, the art program that Patrick and his team put together, dancing, music, all of these things make changes in the brain that I definitely think make a difference for people's outcome. Social engagement is really, really important. A lot of times people have struggle with, low motivation, low energy, like, I just don't feel like getting out and doing X, Y, and Z. And obviously some people are worried about COVID or whatever, but like getting out there, seeing people, like, being in the world it really makes a difference with how people do. And then mindful awareness and meditation have also been shown to help for the symptoms of Parkinson's. And I personally really believe that it isn't just that all of these things I mentioned make a difference for how you feel tomorrow, but rather like, what is the progression of the disease going to look like? So I really encourage people to think about lifestyle choices. Acupuncture, maybe. I mean, I think there's some data that acupuncture can help for stress reduction or improving blood pressure if people have high blood pressure. And that's important for brain health for sure. I think if it helps people sleep, great, but I don't think of it as something specific for Parkinson's. So I really don't have a problem with people getting acupuncture, but I don't think it's like, oh, everybody needs to be doing acupuncture.
Okay, thank you. Here's from someone with PSP. Is there a way to diagnose PSP besides anecdotally?
Great question. PSP, unfortunately, is a very difficult situation, and it evolves very differently from traditional Parkinson's disease. But one of the most informative diagnostic features is what the eye movements look like on exam. That has consistently been shown to be the most consistent, excuse me, I said consistent twice, the most predictive feature of the exam. But there are also MRI findings that can be very consistent with PSP, including midbrain atrophy. And there are newer imaging modalities like the tau PET that we might think could be a diagnostic, but they really haven't been tested consistently enough to be sure that would be diagnostic. So far, really, it's just the MRI and what the exam looks like. And I think we will be able to see more with either blood work or maybe even spinal fluid or the tau PETs, but it's not clear yet if how diagnostic they will be, how accurate they will be in diagnosis.
Thank you. We ought to call this a lightning round. There's so many great questions and we're just firing away. Thanks for that great answer. My 44-year-old son was diagnosed 2 years ago. His main symptom is fatigue and brain fog. Is there an indication of future cognitive decline? He has some stiffness on one side.
Good question. I mean, unfortunate reality is that cognitive decline is common with Parkinson's disease. I should say cognitive changes are very common because a lot of people will notice that they're just not thinking exactly the same way they used to, but that they can still function quite well. But unfortunately, cognitive issues can happen. Predictors for cognitive decline include just really as the disease is progressing and as they get older. So a 44-year-old is going to live with Parkinson's longer. So, when that person is 84, yes, it's very likely that they're going to have some cognitive decline along the way, but exactly when would be hard to know. And then the other kind of predictive factors are, if they have a lot of tremor, they actually have less risk of developing cognitive decline. Again, none of these are absolute. These are just sort of like, what are the risk factors? So if somebody has like no tremor whatsoever, they unfortunately, especially if they start off with a lot of balance issues, that's going to be somebody who's at a higher risk of having cognitive decline. The brain fog and fatigue, I mean, those are very common. So I don't know that I would necessarily immediately think that that's going to be predictive of cognitive decline.
Thank you. Here's a quick one. Is the silver lining questionnaire still available?
Yes. I mean, he's not doing that, that social media aspect of it, but I will find it. He put it in that study and I will send it to Patrick and he can distribute it.
I recently had blood work done and my doctor reported back to me that my dopamine level was high. Based on what you just said, is that possible?
I don't know. It's not the brain. What he's measuring is not the brain dopamine level. So that's different. Like the systemic is different from what's actually happening in the micro, because there's dopamine that manages our blood pressure in our heart. that we call peripheral, like not in the brain. So that's not really relevant to what is happening in the brain.
I read about the vaccine UB312, which intends to slow or stop PD. What are your thoughts on that, and when might it be available? Thank you.
I don't know when it's going to be available. I think a lot of these vaccine type treatments are very promising, but I think that one's still like in process. I don't have specific data on that one.
I was diagnosed with Parkinson's 11 years ago, and of course it is progressive. Why do I have occasions during the day where I have short periods of no tremors? Also, sometimes I sleep smoothly through the night, and other times I move or jerk throughout the entire night while sleeping.
That's a very good question. Bottom line is, it's very, very common for people to experience fluctuations, even outside of those, like what we call on and off. So sometimes people will tell like, oh, I don't have tremor now because my meds are working, or I, do have tremor because my med wore off, even though I'm not due till, 12:30 or whatever the case may be. Sometimes it's unpredictable where they like, I just feel like this med just never kicked in at all. But broader than that, almost everybody experiences good days and bad days, and good moments and bad moments. And sometimes we can tell why. So for example, I slept really well, I'm in a good mood, I exercised a day ago, I'm feeling good right now, I don't really have much tremor right now. And sometimes we have no rhyme or reason. And that can be kind of maddening to people, I find, that they're like, well, I don't understand. Why is it coming and going? And, we just see it a lot. I think there are natural fluctuations in dopamine levels that are available left over in the brain. But also, I believe in the gut-brain connection playing a role in how people are feeling, in terms of how the microbiome, which is the collection of bacteria in the gut, impact how the medications are absorbed, and how that plays a role. So, the short answer is we don't really know why people fluctuate, but it's very common.
Okay, thank you. Incidentally, we have Linda reports that she uses acupuncture and it has a wonderful calming effect for her Parkinson's. Is there a treatment for night terrors?
It depends on what people are referring to with night terrors. There's a very specific Parkinson's related nighttime problem called REM sleep behavior disorder, which is where the person is active while dreaming. So kicking, punching, jumping out of bed, feeling like they're getting chased, feeling like they have to fend off attackers in their dreams. Very classically, they're violent self-defense dreams. And that happens during REM sleep, where the body is not paralyzed during REM sleep as it should be. Yes, there's treatment for that. First and foremost, melatonin. Secondly, clonazepam. Sometimes we have to look at the med list and make sure there's not something that's contributing. When people use the term night terrors, it makes me think they're referring to nightmares, which is a separate thing. A nightmare doesn't simply happen during REM sleep, and has other kind of emotional attachments and things like that. So yes, there can be treatments, but it sort of depends on what they mean by night terrors. And that would be a good question to ask either their neurologist or even a sleep specialist.
Okay, thank you. We're going to wrap up with one more question. These questions were awesome. I'm sorry if we weren't able to get to all of them, but last one here. I was diagnosed 5 months ago. Then I became motivated to deal with obesity. They had a BMI of 36. Quickly, under their care, primary care physician supervision, with severe calories, they use severe calorie restriction plus dramatic increase in exercise. They have been losing weight rapidly now at a BMI of 31. Is rapid weight loss contraindicated?
No, we worry about weight loss when people are sort of going into an underweight range, as well as when people are losing weight without really intending to. Like if somebody's really being very diligent about their diet and exercise. My concerns about this kind of speed and the severe caloric restriction is it's often unattainable. So unfortunately, a lot of people, and this has nothing to do with Parkinson's, will sort of yo-yo in their weight. So it's really a good idea to find something that's sustainable and that you still feel like you're able to enjoy your life, you know, rather than it being an over restriction. But if somebody is exercising, one of the key points is strength training so that they can maintain muscle, because it's common for people, especially as they get older, once they lose muscle, it's very hard to build it back. So everybody needs to be doing strength training to maintain muscle bulk and bone density. So when people lose weight, unfortunately, it's common to lose fat before they lose, to lose muscle before they lose fat. And so, you know, you want to be very mindful of the weight loss being the right kind of weight loss and to be a sustainable lifestyle for the long term. So congratulations.
Yes, that's quite an accomplishment. Well, thank you so much, Dr. Proshin, for spending this time with us. We're very, very grateful. Let's give her a round of applause, virtual applause. Thank you, thank you, thank you. Is your PowerPoint going to be available?
I'll email it to you, and I'll find that silver linings questionnaire for you too.
Okay, thank you so much.
Or maybe I'll email Sarah.
Yeah, that's best. Yes, thank you.
Okay, good.
All right. Well,
all right. Thank you for having me.
Thank you.
Really appreciate it.
Absolutely. So for our community here, final quick couple of notes. We hope you will join us for our upcoming Let's Talk Parkinson's event, which include programs on caregiving and cannabis and Parkinson's. You will receive information on how to register for these events soon through your email. We are excited to announce that PCLA has been selected to be an official charity partner for the LA Marathon and the LA Big 5K race. If you are interested in the Los Angeles and in the Los Angeles area, we invite you to join us for the Big LA 5K on Saturday, March 18th, 2023, to help us raise funds to continue our mission. Join us. You'll receive an email soon with details on how to participate. Again, today's event was made possible by our sponsors, Abbott, AbbVie, Boston Scientific, Medtronic, and Supernus, and by you. If you enjoyed today's program, please consider making a tax-deductible donation at PCLA.org and help us spread the word by sharing our organization with your medical professionals and your network of friends on social media. Thank you, everyone. Stay safe, stay well, and don't forget to vote.